Welcome, everybody. My name is Leah Stevenson. I'm here with Louise Binder, and I'm very pleased to get us started today on our third and final pre-summit webinar entitled Canadian Jurisdictional Roles in Health and the Determinants of Health. Some of you may have joined us for our first two webinars, the first focused on the determinants of health and the second on Indigenous determinants of health. And we're very pleased that you're able to join us today, where we go a bit more into the complex jurisdictions and who's responsible for what as it relates to health and the determinants of health in Canada. All of these webinars are meant to be preparation for our upcoming big event. There'll be some more information about that at the end of the webinar, but it is the Patients Redefining the Future of Healthcare in Canada Summit. It takes place on November 15, 17, 18, and 19, a few hours per day, starting at the same time as this webinar, noon Eastern, 9 a.m. Pacific, et cetera, across the country. And the event, as well as these webinars, are co-hosted by Save Your Skin Foundation and the Canadian Psoriasis Network, plus co-organized by an Indigenous partner and myself. So let's get going. But before we launch into our content, we deeply want to thank our sponsors, without whom none of this would be possible, and including and especially Axon, who is an in-kind sponsor and is kindly providing the technological platform for our webinars and for the event. So thanks to all of you. We couldn't do it without you. And before we jump in here, I just want to briefly introduce Louise Binder, who many of you I trust will know and have worked with. Louise is a lawyer and a health advocate who has been involved in informing the development of health policy and systemic treatment access practices from the patient perspective since the early 1990s, subsequent to her own HIV diagnosis. Louise co-founded the Canadian Treatment Action Council in 1996, which is where I had the great pleasure of getting to know her and working alongside of her and learning a lot from Louise. Louise then began similar work in the cancer area and is presently the health policy consultant with Save Your Skin Foundation. And she's been recognized, rightfully so, for her incredible work by many organizations, including an honorary Doctor of Laws from her alma mater, Queen's, the Order of Ontario from the Province of Ontario, and a couple of Queen Elizabeth II medals. So over to you, Louise, to help us better understand the roles of the different levels of government in health in Canada.
Thank you. If we can go back to the very first slide with my leaf on it. There we go. I like this. Welcome to all of you, by the way, and thank you for joining us. The intention of today's presentation is to give people just some basic background information about the roles that different public bodies play in health and also private insurers, and to talk a little about the implications of the determinants of health on one's ability to both access and to have optimal health outcomes as a result of your social determinants of health. So the reason I like this little snaily slide is because to me it kind of speaks to all the stakeholders in this, in my view. So from the patient's perspective, and often the patient representative's perspective, it is, if you don't know where you're going, any road will get you there. And the reason I think it applies to us is, as you'll see in a few moments, our jurisdictions in health are so complex for a country that shouldn't be this complex, that we often don't know who does what in health, and therefore we often end up asking the wrong public or private jurisdiction to help us with something that isn't within their jurisdiction. So it's very complicated for us, and it's a very complicated in my view, I get the impression a lot of the times that even the policymakers aren't too sure which road they ought to be, what's their road and what's somebody else's road. And I think I've personally seen a lot of that through the pandemic. And so I'm not sure that the people who actually manage our healthcare system always understand whose role is what. So I like it because I think we're all in the same complicated soup in Canada, all the stakeholders. So now if we could move to the, there we go. So when we're talking about, I do work in health policy, and people say to me, you know, kind of, what's health policy? I'm not sure I know either, but it seems to me that it kind of is managed in three ways in Canada. One is through laws and public policies that are made at both the federal and provincial levels, and we'll talk about the differences in a few minutes. And so that's like laws. So the Food and Drug Act is a law that deals with health. Health procedures, there are sometimes guidelines for particular diseases and how to manage them. And those are kind of under law and public policy. So we also have a layer, which is the implementation stage. So the policymakers, the political policymakers and the bureaucrats make a lot of the law and public policy. And then the civil servants, for the most part, implement them. And hospitals implement them when it comes to health delivery. In hospitals, the doctors implement them, as well as government bureaucrats. And then the third part, which I personally think we don't do a very good job of, is monitoring and evaluating the outcomes of our work in law and public policy and implementation in terms of outcomes and whether we're really being successful with the approaches that we're taking. But those are the kind of three tiers of health system policy that I tend to, the way I tend to think of them. So who does what in the public sphere? This is the overall lay of the land in terms of drug coverage, patient access to drug coverage and treatments. And I'll be going through these in more detail, but just to give you a sense that this is a complicated process that we have in this country. So we start out with drug development, which is up to the companies, manufacturers, whoever decides they want to try to develop a drug. Some of our academic institutions do drug research and development as well. In general, the rule has been that it takes somewhere between 7 and 10 years to develop a drug, although it seemed to take us a lot less time when it came to vaccines for the pandemic, which hopefully will be a message for us in the future that we don't have to take that long to start looking at important innovative drugs before we get them to Health Canada. So once a company, whoever's been the researcher and developer of the drug, has finished their trials, and usually we talk about trials in three phases. Well, the first is safety of the drug. That's a very small group of people that we try the drug out on to make sure that it's safe. And they're usually not people with the disease, but they're healthy volunteers. Phase 2, we bring in some patients and we look at both safety and efficacy with not a large group of people. But then if that works well, we generally go to phase 3 of a trial, which is where we have a much larger cohort of people in the trial to get a good sense of the safety and efficacy of this drug, at least for the term of the trial. So once the researcher feels comfortable enough with their data sometimes at phase 2, usually after phase 3. And by the way, Health Canada approves the trial, clinical trials going ahead as well. They have a section that approves the clinical trial protocol. And then at the end, they will approve or not approve or conditionally approve a treatment for sale in Canada. And that's based on the safety and efficacy of the trial and an assurance that there will be good manufacturing practices. Now, you'll see beside Health Canada that I have a kind of a dotted line that says the Canada Drug Agency. The reason it's in this kind of uncertain state on my chart is that for the moment, this agency has just been announced within the last couple of months. It, for the moment, is transitionally, according to the government, being managed through Health Canada. And so I put them beside Health Canada. We don't know if that's where they're going to land or not finally. And we also really don't have any idea what this agency is going to do specifically, but it does exist. So for the moment, if Health Canada agrees that this drug from the trials shows itself to be safe and effective, then it moves to the Patented Medicine Prices Review Board to make a determination about whether the price that the manufacturer, researcher wishes to charge for this drug in Canada is, quote, not excessive. That's the language in the Patent Act and regulations that has responsibility to make that decision. So to this point in our chart, we are at the federal government level. The federal government makes the decisions about the clinical trials. They make the decisions about whether the drug can be sold in Canada and at what price is not excessive. So at that point, all of that is done through the federal government. And then we move to a pan-Canadian approach, which is health technology assessment. And we'll talk more about what that does in a few minutes. But it's a pan-Canadian look at the drug to determine whether it should be reimbursed at the public reimbursement level provincially. In Quebec, that's managed through INEF. The rest of Canada, it's managed through an organization called CADA. Assuming that it gets either a conditional or non-conditional approval as a valuable drug to be considered by the provinces for reimbursement, it goes to the Pan-Canadian Pharmaceutical Alliance as a file to negotiate the price of the drug under the public reimbursement system, both for the provinces, territories, and some of the federal plans as well. Hospitals have their own list of drugs that they cover and pay for, and that's also at the provincial level. That's done at the provincial level, and then each provincial drug plan makes a decision about whether or not it's going to add that treatment to its reimbursement list, public reimbursement list, and patients then finally get access. And of course, there's also some private drug plans. We'll talk a little bit about that, but not too much. So as you can see, if it takes 7 to 10 years for a drug to be developed, and then it has to go through all of these other processes, it can be literally years for someone to receive a drug that they desperately need quickly in order to have a good outcome. So if we look at if we start to take this chart apart, we go to the next slide, you'll see. So as I've mentioned, this is a point that I think many Canadians still haven't got figured out, and I understand why. We talk about the federal government ensuring that we have universal access, but they don't actually commit to that. They commit to universal access to doctors and hospitals across the country. That's in the Canada Health Act. There's absolutely no reference to paying for drugs at the federal level, although they do pay for some drugs for particular populations. I'll talk about that in a few minutes. But for the most part, it's the provinces that make the decisions about which drugs to reimburse and to put them on public reimbursement formularies, listing. So this is a big mistake that Canadians fall into a lot, is this belief that somehow they have a universal right to drugs. And legally, they only have the rights that the provinces decide to give them. So as I've mentioned, the federal government also approves clinical trials. It approves the sale of them, and it also can, through Vanessa's law, a fairly recent piece of legislation, it can actually remove drugs from sale, which it couldn't do before that. As I've mentioned, it looks at the price of drugs to make sure it's not excessive. When we're in a pandemic situation, it manages the public health policies under that through the Public Health Agency of Canada. And the federal government manages insurance companies through insurance company legislation. So those are the laws at the federal level. And I can't repeat often enough the fact that there is absolutely no reference to the payment for drugs by the federal government in federal government legislation. Okay, so that throws it all over to the provinces. They implement. Now, this is where they actually do provide drugs directly for their own employees and retirees, for the military, the RCMP. They provide drugs for Indigenous peoples on reserve and people in federal penitentiaries and refugees. They actually directly get drug coverage from the federal government, but they're the only one. So they often, the federal government will have special health strategies. They have a strategy for HIV, they have a mental health strategy, they have a cancer strategy, but we must keep in mind that they only have certain jurisdiction within any of these areas. And sometimes you will see that there'll be best practice guidelines that are actually created federally. So that's the federal government's role in implementation. And in monitoring, as I've mentioned, they do monitor drugs post-approval. They do monitor excessive drug pricing. They transfer payments for health to the provinces, sometimes with conditions, through Canada Health transfers. And I'm sure you've heard quite a bit about Canada Health transfers recently. Those transfers have not been increased for over a decade and have continued to increase only by 3% per year, which really, given the circumstances, frankly, that we were in even before the pandemic, and certainly now, is not going to be sufficient to make up for all the catch up that we need to do, as well as getting ourselves a good health system. There is data collection done at the federal level, health data collection. And as I've mentioned, for infectious disease data, the Public Health Agency. So that's the federal government's role in health. There are a lot of issues that this pandemic has unearthed. Some of us knew about them before, some of us didn't. We're going to have to look, I think, as a country at our, certainly at our pandemic planning through NACI, which is the national organization that's responsible for implementation, vaccine approvals and implementation. Pharmacare is still being discussed, but very much linked to what the provinces are prepared to do, so that could be difficult. There's a lot of talk about a rare disease strategy. We are going to have to definitely going to have to do something about a pan-Canadian process for the management of seniors. We have now virtual care being integrated much more fully into the management of our health, and the questions of where that's appropriate, where it isn't, and how to ensure people get access to it are all going to be big issues I would suggest to you over the next Parliament. There have been further changes to CADA, and we'll talk about CADA in a few minutes. About that, Health Canada is moving towards a more what they call agile review regulations, including rolling reviews of files that come in. This is something that we've been pressing for more than 25 years. And what it means is that that Health Canada can start to review data that come in from the manufacturer, the researcher who would like Health Canada to approve the drug, and that they can actually start looking at those data as they come in, rather than waiting for all the data to come in before they even pick up the file, which of course wastes a lot of time. A lot of talk about real world evidence and real world data these days. And I'm sure a lot of organizations, both federally and provincially, are working on this. There's a lot more talk about somehow finding a way to use risk-sharing agreements, pay-for-performance agreements, and other ways of sharing the risk of the safety and efficacy of a drug with the manufacturer who's selling it. And of course, we've got this whole problem of pandemics, the ongoing pandemic, they're really becoming pandemics because of the different types of variants we're seeing, and also what are being called echo pandemics. So because mental health, the way older adults have been treated, and certainly the delays and cancellations in cancer and other diseases, these are just examples, we are going to have quite a slog getting back to anywhere near some kind of a reasonable healthcare system, in my view. So these are going to be big issues. So that's the federal government, and they have overall responsibility for those issues. Now, the provinces and the federal government, to some extent, collaborate on health as well as overarching issues that are synergistic. So one of them is this whole question of health technology assessment. The purpose of a health technology assessment body is to take a look at a drug that has been approved by Health Canada and has been found not to be excessive in terms of pricing. But the question is it of value to the public reimbursement system such that it ought to be one of the treatments chosen to be paid for publicly? And that's the role of CADA, which is the Pan-Canadian Reimbursement Review System, and INES for Quebec. And what these systems do is they make recommendations to the provinces about whether, yes, this is a drug that's of value and it's properly priced, or it'll be of value if you get the right price. And they make those recommendations to the provinces, which the provinces can accept, amend, or ignore. And then we have the joint pricing negotiation body for public plans called the Pan-Canadian Pharmaceutical Alliance. And so what the provinces do, and a couple of the federal plans as well, is they come together to negotiate a price for the public reimbursement system. That still doesn't mean that a province needs to take that drug on board just because they agree to the negotiated price. That's still up to the province. But at least they come together to try to find a price that they can accept. So that's kind of their law and policy work. Their implementation, there's many types of implementation. I've given a few examples here. So there's a Canadian Association of Provincial Cancer Agencies that deals with overarching cancer issues. We have groups, lots of federal, provincial, territorial health leaders, deputy ministers meet together, ministers meet together, and so on. And we have what's called the Council of the Federation, which are the premiers. And they're actually the ones who created the Pan-Canadian Pharmaceutical Alliance. And they're supposedly going to be meeting soon to talk about the Canada Health transfers. So I think we need to encourage them, to encourage the federal government to increase those transfers. I would also argue that they should make specific allocations for funding in particular areas such as mental health and cancer and seniors and others that have been so profoundly adversely impacted by this pandemic. So that's so now we're at the provinces, and everybody talks about this patchwork quilt. I'm sure you've heard that expression. Well, why is it that we have a patchwork quilt of drug and health policies across this country? It's because most health systems delivery and drug reimbursement plans are determined by the provinces, as I said earlier. And they also develop specific programs for particular populations within their borders, seniors, cancer. Each province has a cancer agency, mental health, and so on. And they also develop Indigenous health programs for Indigenous people off reserve. So that's what the provinces do. And that's why it's a patchwork quilt, because they're each making their own decisions in each of these areas. So if we move to the implementation, it's also a patchwork quilt because each hospital and it makes its own decisions about what it's going to cover within the hospital, what drugs are going to be provided to patients within a hospital, how the emergency rooms are going to work. They make all those decisions. Pharmacies are provincial. So many things are within the provincial jurisdiction. And since all the provinces are very different, you get this patchwork quilt where you can get one thing in one province, but not another. There's some types of opportunities in one place that we don't get in another. So it's complicated. The provinces manage the cancer agencies. They do data collection for the provinces. They have a huge bureaucracy. They manage clinical trials and they implement public health measures, often with municipalities to help out particular municipalities that have particular public health issues. So that's the provinces, and they also monitor and evaluate. Again, this is an area overall that I don't think we do that well in Canada, but we do have budget control through each ministry and treasury board. Those of you who know me know that I don't like the way we budget in health. I don't think we should be budgeting by type of activity, but rather by population. So right now in the province of Ontario, a certain percentage of the health budget is put aside for drugs, a certain percentage for hospitals, a certain percentage for doctors, and so on. I would make an argument that that's upside down, that what we should really be doing is budgeting by population need. What do cancer patients need? And therefore, how much money will that cost? And that's how we should budget. That would be my argument. It's not only mine, I assure you. We have some quality control programs, and of course, we have health advisory boards and committees at the provincial level. So it's all very complicated and all very patchwork because, again, each province will make its own decisions about these things. So we've got to the provinces, and then there are private insurance plans, which you can purchase, your company can purchase as a group plan, your unions, if you happen to be involved. If you belong to a professional association, they can often negotiate better prices for private insurance and so on. The idea about private insurance was supposed to be that it added to what you were already able to get through the public reimbursement plan. But there's been a lot of clawing back in the private insurance field as well, in terms of what they're prepared to pay for and what they aren't. So that's the kind of the landscape, if you like. And so just to show you that very first slide in a different way. So we start with market authorization. In other words, the authorization to market a particular drug. And that's managed at the federal level. Oh, I apologize for that sneeze. At the Health Canada level, they decide safety, efficacy, and manufacturing, good manufacturing practices. And if they feel that these drugs are safe and effective and that there will be good manufacturing, they can give it a notice of compliance, which is what they call an approval, another way of saying approval. Sometimes there's what they call an NOCC, which is a notice of compliance with conditions. In other words, yes, we will, but you need to do the following further trials, or you need to do something else. You need to reduce the price, et cetera, et cetera. And then, as I mentioned before, if Health Canada says, yes, you can sell it, then PMPRB decides if it's an excessive price that you're proposing for it or not. If they say it's not, then it keeps moving through our system and moves into the pan-Canadian area past the federal government to our health technology assessment recommendation bodies, CADAS and NES. Then it goes down. It can, some things do not go through, by the way, those bodies, not that many things, but some things don't go through them. They go directly to the provinces to make a decision themselves. And of course, we have the private plans. And then there's individual formularies. So CADAS will make a recommendation to all the provinces, and private plans, drug plans are generally national, across the country. If they're national plans, they won't be different one province to another. And then after all of that, we get to individual formulary decision making, which is still in the hands of the province. And they will take a lot of factors into account in making that decision about whether to reimburse or not. I've listed some of them there. And as I said, and I've just put it over kind of to the side so you know that I know it exists, the Canada Drug Agency, but I think there's just too much we don't know about that yet in terms of where it's going to report and so on. So that's the health policy / implementation world that we live in, rather precariously.
Thank you, Louise.
Over to Leah.
All right. Hopefully our heads aren't spinning too much with our wonderful layers upon layers of roles amongst the different jurisdictions. Louise, thank you so much. I think you managed to make that as clear as one can make such an unclear topic. Now I'm going to add some more messiness into the conversation. So we're just going to briefly touch on a few examples of sort of who does what in the various jurisdictions. And I'm going to bring the municipalities into this one too, in the public sphere as it relates to some of the determinants of health. And just to ground ourselves again in what the determinants of health are, in case you weren't able to join. our webinar a couple of months ago, and if you didn't, it is online. Do take a look at it. It was fantastic. So this definition comes to us courtesy of Health Canada, and reminds us that the determinants of health are the broad range of personal, social, and economic and environmental factors that really shape our individual and our population health. And some of the determinants of health are included on the slide, such as income, social status, employment and working conditions, education, racism, gender, our physical environment, access to health services are all examples of determinants of health. And it's important to state and emphasize that experiences of discrimination, of racism, of trauma, and intergenerational trauma are really important determinants of health that particularly affect populations and communities within Canada, such as Indigenous peoples, Black Canadians, LGBTQ++. So just to remind ourselves of what the determinants of health are. And so now I picked three, or we picked three determinants of health to give a sense of sort of what are some of the, who does what, and who has primary responsibility for what at the various levels of government within Canada. And I may have not thought of everything. So by all means, if there's things that have been missed, even in these three, please share your thoughts in the chat or the Q&A box. So Louise already covered really well in great detail the allocation of jurisdictional responsibilities related to access to health services, which is a determinant of health. She specifically focused in on the treatment side, but I think touched on quite a few other aspects of healthcare across the country. So here are three other examples of three other determinants of health. Income is an example where I think there is a lot of blurring between three levels of government, and I'm sure there's a historical reason for this. I think that probably income and income supports was not something that governments thought a lot about or got particularly involved in for quite some time in the history of our country. But I think it's really important to point out that the provinces and territories play a very important responsibility when it comes to income, in that they have the primary responsibility for legislating employment standards, as well as providing social assistance or determining, who qualifies and what type of social assistance is available, etc. In education, the provinces and territories also carry a lot of the weight related to education. However, it's important to point out that the federal government is vital for providing financial support to afford education, but they are also responsible, similar to with healthcare. Louise pointed out that they have direct healthcare delivery responsibility for a certain number of people, of populations within the country. So do they when it comes to education. So specifically, the federal government has direct education delivery responsibilities for Indigenous peoples on reserve, for the military and Coast Guard personnel, and for federal inmates. And also to point out that municipally elected school boards undertake a lot of local implementation of elementary and secondary education. So again, we have a mix of responsibilities when it comes to jurisdictions in the determinants of health. And then finally, looking a bit at physical environments, so really sort of our infrastructure. And if you think about how important this is, access to public transit, access to healthy foods, to be able to get to, having accessible healthcare and culturally safe healthcare available in the right areas. These are all safe parks, good lighting, et cetera. All of these have a big impact as it relates to our determinants of health. And I want to point out in this one that that the municipalities really carry a lot of responsibility related to infrastructure and the physical environment, as many of our infrastructure assets are very local in nature, from municipal land use and determining, planning how land will be used, and taxation, to local parks, to public lighting, public transit, recreation, community infrastructure, local roads, water, sewage, waste management. These are all municipal responsibilities in our physical environment. But the provincial and the federal governments have their own responsibilities as it relates to the infrastructure in their jurisdictions, but they also really need to play key roles when it comes to infrastructure investment at all levels of government, including the municipal level, because public infrastructure is a common good. It is expensive. It's a long-term planning and expenditure and benefit, and usually requires joint planning. So there are important cross-jurisdictional roles here, and it can't just be left on the municipal shoulders. So we wanted to point out a few of these examples of who does what as it relates to the determinants of health in the government, in our jurisdictional landscape, for similar reasons. We're understanding more and more how important integrating determinants of health and healthcare are. That some estimates are 80% of our health is shaped by the determinants of health. And so it's a huge factor for those of us, for patients, caregivers, and others, when we're trying to improve outcomes for people in Canada and for patients across the country. So having an understanding of who does what and who should we be talking to about these different issues as we try to engage on what's important to our stakeholders, it's helpful to start to unpack some of the roles and responsibilities. So hopefully that was a little bit of a taste on the determinants of health and jurisdiction side. Hopefully it was helpful. I'm going to pass the microphone one more time back to Louise, who's going to now just give us an overview of the Patients Redefining the Future of Healthcare Summit, and where does the summit fit in all of this. Thanks, Louise.
Thank you, Leah. So 6 years ago, I had this idea. I recall it only too well. It was in the fall, and we had just learned that the Patented Medicine Prices Review Board was planning to make significant changes in the factors that it considered in determining whether a price of a drug in Canada was excessive or not. And one of the things they planned to do was to do a consultation with all the stakeholders before they made these changes. And it occurred to me that I had no idea really how they looked at excessiveness, except what they say in their regulations and guidelines, but that truthfully it's very complicated, and I thought it made sense if patient groups and patients were going to be asked to give advice on such a complicated matter, that we have some conversations together about it as patient groups, those who are interested. So that was the reason actually for the first summit, was to basically do a lot of what we've done today, which is to contextualize all the different parts of our system, and to understand at that point, particularly where the PNPRB fit in there, because they were about to do these consultations. But it was important to understand the other parts of the system as well, and where they all fit in. So the evaluations from that first year recommended an annual event where patients got to work together, action planning. And I had never really intended this to be an annual event, but at least to this point it is. At the second summit, we moved away from more specific information about the way the Canadian healthcare system works to the question of, okay, we see how it works, how would we like it to work? And so at the second summit, we introduced the concept of value-based healthcare with some key principles that were articulated by two doctors in the United States in a book called Redefining Healthcare, which I was fortunate enough to learn about, to read about, and to endorse personally. And then I found out that there was a whole international group called ICHOM that also was, it's the I'm going to say this wrong, International Collaboration for Health Outcome Measures. Maybe I didn't say it wrong. And that, so, you know, it wasn't my brilliant idea that value-based healthcare was a good idea. People a lot smarter than me had thought about this already, but it made sense to me. So at the second summit, we had people who were experts and had worked with Doctors Porter and Teisberg to talk about what value-based healthcare was. And so at the second summit, and by the way, I want to be clear that the summit is a patient summit. It is intended for patients to be we both make the decision about the agenda for the summit and the implementation for the summit, and we're the decision makers. We, the patients, and patient representatives are the decision makers of the summit. We do invite observers for the main part of the presentations, but our work planning is all done at the summit behind the scenes. So the second summit, as I mentioned, we brought in the concept of value-based healthcare, and in general, patients said, yes, this would be a much better system for us to bundle the services really around populations and their needs, rather than slicing it by where that particular health system is, how it's managed. So instead of 6% for drugs and 10% for this, and 20% for hospitals, I'm making up these numbers now, I promise you, that we should in fact look at what populations need and divide the money that way. Also taking into account Leah's additional lens, which is to do with determinants of health, because you can be a patient, you can be a cancer patient, but there's lots of different kinds of cancer patients. I don't mean just by type of cancer, but also in terms of the social determinants of health. And how do we make sure that all of them get served, not just those who are fortunate enough to have a lot of access to social determinants? So we started to set up some working groups to work on value-based healthcare. And at the third summit, we really drilled down on some of the principles of value-based healthcare that really needed attention in Canada. And we decided that they were data collection and data rights, integrated models of care, because you can't bundle services and provide good service to people when we're siloed, and patient-reported outcome measures, which are the measures that patients tell us they want as a health outcome for themselves. And it's from that one makes the decision about how to bundle services. So I'm very proud to say that our working groups have developed a really amazing document on our Declaration of Rights for personal health care, and what rights we have to those data and to others using those data. And this document's been widely distributed. If you haven't seen it, please let us know. We'd be glad to share it with you. And we've also started to develop ideas about patient-reported outcome measures and how to enhance those, as well as what would a really good integrated model of care look like. Do we have some best practices in Canada? Don't we? And we've had lots of conversations about those. So moving to the next slide, just to be clear about the definition of value in the term value-based healthcare in this context, it's not the same one as health technology assessment at all. Value in value-based healthcare is the outcomes of importance to patients divided by the cost across the care continuum to ensure that we get to those outcomes. So that's the definition. And it's important to understand the difference. So then we had our fourth summit, and I'm really honored to say that we were joined in that by Sharon Clark, who is an Indigenous woman who has worked at CIHI and our Canadian Institute for Health Information. She's also worked at Queen's University in the Office of Indigenous Affairs, and I know she has a new job in London, Ontario, that I will not get the name right, so I'll wait and let her tell you about it at the summit. And last year, we rolled in not only Indigenous populations, but we brought in the whole concept of inequitable health outcomes, particularly how they've been exacerbated by COVID. So we talked particularly about people with mental health conditions, older adults, and people facing income insecurity, as well as in discrete Indigenous perspective. I strongly urge you, if you haven't had an opportunity to take a look at those two webinars, I strongly recommend them. The first one is actually a group of people that belong to an organization called Empath, and it's a group of people who have had real health inequity problems because of social determinants, and they talk about their experiences, and it's stronger than any theory that I could ever give you. And of course, our social determinants of health on the Indigenous stream also was really amazing. We had an Indigenous presenter, a doctor, who just did an amazing job for us. So now we come to this year, and every year we kind of build, I think. This year, we want to talk very specifically about the echo pandemic coming out of this pandemic. I have to be honest, I'm always trying to be honest, but at the time we started developing this, I thought we'd be a lot farther out of the existing COVID-19 pandemic than we are. So yeah, anyways, I can't resolve that problem today, sorry folks, but I hope you'll join us for our 6th annual summit. And there's the list. If you haven't registered, please do. We'd love to share with you and to build with you an action plan for next year to come out of this pandemic, hopefully with a whole new concept of healthcare and how it should be managed. I don't actually want to build back better. I want to build back something new. So, so hopefully you'll agree that value-based healthcare is one of the ways that we can do that. So that's that.
And I'll just jump in again to give one more shout out and enormous thanks to our sponsors, both of the webinars as well as of the upcoming summit. And just to let everyone know that the registration and the details, the launch, the event page for this year's 6th annual Patients Redefining the Future of Healthcare in Canada Summit should be coming out today. So keep your eye on your inbox. And the dates are the 15th, the 17th, and the 18th of November. The 19th is a shorter day, and it's for patients and caregivers and representatives from patient groups and citizen groups, et cetera, to participate in the 19th. That's our action planning day. But the 15th, 17th, and 18th, and that's open to absolutely everybody. And all the days are starting at noon Eastern time. So 9 a.m. Pacific, what's that, 2 on Atlantic side, something along those lines. Anyhow, if you don't have it already marked off in your calendar, please mark it off and keep an eye out for the invitation, which should be any moment now in your inbox. So thanks again to those sponsors. And then we have 5 minutes left for any questions. So Louise, feel free to come back on, because I think we have a couple of questions, and whoever, if you want to take it or I want to take it, it's all good. So question number one, a good one here. How do we begin to move away from siloed budgets and towards a population-based funding structure? You want to go first? Or do you want me?
Sure, make me try to figure this one out in 5 minutes.
I can flail if you want me to.
You can start.
I know I'm referencing here some examples that I know are happening at regional levels, for example, within Ontario. So I'm Ontario based. I'm sorry, it's my bias. I acknowledge it, and I've worked in the Ontario health system for some time, so I know the stakeholders in the province a bit. But I'm going to generalize out of what I've observed, which is there are efforts happening to organize all the providers in regional groupings to be responsible for the entire population within a given region, but then to think through population health measures further so that they are working together across all of their organizational and provider type boundaries in a cohesive fashion to, yes, serve the entire population better, but also focus on specific populations to work on and improve upon one step at a time. So many of them are focusing on mental health, for example, or seniors who have particular vulnerabilities or comorbidities, et cetera. So there's this organizing that's happening that is encouraging all of the different providers in a region to say, okay, look, we need to look at quadruple aim outcomes to begin with. So how are we improving patients' experience and outcomes? How are we improving population health? How are we improving sustainability and cost effectiveness for the healthcare system? And how are we improving the lives of the providers too, so they're not so burnt out and don't feel like they're fighting within a fragmented system and are able to better serve patients? Within all of that, as they start developing specific targeted approaches for different populations, that's where I think the proms and the prems start becoming absolutely vital. And having some infrastructure to say, okay, how are you holding everybody accountable within this grouping of providers who are now trying to work together in a more integrated fashion for specific populations within a given region? How are we holding them accountable to outcomes instead of, and how are we budgeting? So one of the things that they're talking about over time, we'll see if anyone actually does it in Ontario, is moving towards bundled payments. First, getting a better grasp on, okay, what are the costs to achieve across the continuum of care to achieve these better outcomes? Who are the different players and what do those costs look like, et cetera? And then, providing these bundled payments to say, okay, this is how much you're going to get across all of your provider types, right, in order to work with these different population groups. And if you manage to spend less than the amount that you've been allocated, you can keep that and reinvest it into improving better frontline care. And if you spend too much, well, you're poop out of luck. So there's a variety of things happening here. One is creating the collaborative governance of more integrated planning and service delivery by having the different providers actually both carrot and stick, but really there's a certain requirement that needs to happen here to make them work together. Otherwise, the status quo of a fragmented system is just going to keep people confused and stuck. And then there is the outright focus on outcomes, on population health and specific needs of different populations within an area, of then saying we're going to hold you accountable for those outcomes and ultimately doing that, and then figuring out funding mechanisms that work across provider types and that work across the continuum of care for these different populations, and building those into those accountability agreements over time. Those are some of my thoughts.
I'll just add one thing, and that is that you can't, in my opinion, the only people whose opinion matter at the end of the day about how things should be structured are the populations that are being impacted. So one of the important things, in my view, is to build relationships with these different social determinant groups. So there are groups that are working very hard with older adults. So we're building relationships with those groups. We're building relationships, I hope, good relationships with Indigenous populations, and recognizing that they need to take the lead on what they need. So I think that's a very important thing, is bring in those populations, even those that don't work necessarily in health, but they will know what's going on with people's health. And that will help us to do our advocacy towards bundling, for sure.
Nothing about us without us in co-design, absolutely. That's
right. And the last question, and we only have, I'm sure we're probably over time already, what are some things to look for in our new Minister of Health? Well, I think the first question will be, is this Minister of Health going to be given any power to do anything on his own? Now that, it's just me speaking, but the last two Ministers of Health have been pretty weak, in my view, and in terms of really being leaders in health. So maybe we'll be more fortunate with Monsieur Duclos. He's certainly been around for a long time and knows the ropes. So maybe he'll be given, more power to do things himself. That certainly, as I say, hasn't been my experience so far under this government. And I guess I wish I had a better sense that the federal government had a plan for health, other than the pandemic, of course. I don't think they planned for that either, but we really need a plan for Canada for health, and it's got to be federal, provincial, and territorial. So I hope that this particular minister will bring together his counterparts. I know they certainly want to meet with him at the provincial level and see if we can't work out something that's more collegial in terms of solutions to what are going to be really, I think, profound health problems coming out of this pandemic. Sorry to end on that note.
No, I think you took us back to that first slide and that cartoon of, let's go on a road trip. If you don't know where you're going, any road will take you there. So until we have that, that vision and that agreement on principles and how we're going to get there together across jurisdictions, I have to agree with you. It's just, so a plan would be nice, and an acknowledgement that when you are in that leadership position, you have power. So pick up the staff and do something with it. And we are 3 minutes over. So for those of you, the 24 of you who stayed until this point, deepest thanks from Louise and myself and from all of the organizers of the summit. We sincerely hope that you are able to join us for all the days of the summit. We have fantastic speakers and really interesting content coming up. So be there or be square. Thank you very much, everybody. Have a fantastic rest of your day.
Bye-bye.